allowing us to present and share with you part of our journey. And I think a few sessions ago, there was a discussion of what topics and what items were interest to the group. And one of them had to do with the area of finance. So we're going to talk about finance from a different perspective. And I think is that we have all experience in our careers and in our facilities, challenges associated with the justification of projects, right? And so what we're going to share with you is our journey. We've also experienced the same challenges, and we've learned to basically uh, ask questions and do research and apply the research to establishing a new methodology that we can communicate with our executive suite and be able to share with them more specifically some of the issues that are significant to us from a compliance perspective. Um, so, my background, I'm the Senior Executive Director of Facility Safety, Compliance, and Continuity for the University of Miami Health System. We have about 2.5 million square feet in the healthcare system, and the medical campus is over 5 million square feet. And we have under one umbrella, we are one entity for the purposes of CMS of the Joint Commission. And we have about, I believe right now, 19 entities that are part of that UHealth system. So our Joint Commission surveys are as an entity, and certainly there are challenges associated with the aggregation of all that data. And that's why our department was established. So, Walter, will you introduce yourself, please?
Yeah, so Walter Lamar, Dr. Walter Lamar. So my PhD is actually in public safety with a specialization of emergency management and a concentration in public health. So this has kind of been the longest Super Bowl I've ever played in when it comes to the management of this virus. Particularly, we try to communicate from a behavioral based standpoint, since my background is in social sciences as a disaster scientist. And I think we've done a pretty good job of making sure that the things that we implement are one, practical, but two, it doesn't cause an individual to uh, think about a lot of things. Because the moment we start asking a person to think about doing something that they would naturally do, that's that core component where we return into or push the person towards error. uh, but with the behavior-based system, what we try to do is establish the natural behavior and safety practices along with what a person would normally do. So it decreases the thought of I have to do this or I have to remember, and it's so far as been efficient. So right now we're working on a theory to pandemic management, which I think the vast majority of the world has been doing a couple of things a little bit incorrectly. And it is because we have historically used the wrong model, as by the CDC and OSHA. So more to come on that. But if you all are a part of the Grainger Summit coming up, we will be speaking and I'll be talking about the model.
Right?
So the general objectives that we're going to try to establish here is there is always going to be a challenge of obtaining capital funding. Uh, One thing that I make sure that we do, and Jose would also agree, is properly communicating a specific message to a group of individuals who particularly don't speak your language. So understanding the language of the C-suite and the clinical stakeholders is a huge one. We also do what we call translating capital requests, because we cannot expect the individuals who are the recipients of the message to absolutely understand exactly what we're saying. It's our job to tailor the message to the individuals. And I know we hear this a lot, but in many cases, we're ineffective in that, which tends to get us into the situation where we don't obtain what we need. The failure modes and effects analysis is something that we have used for quite some time now, just a research-based practice. So we'll get into that. And the basis of it is kind of a photo as compared to many more words. And we'll show you some of our $1 million FMEAs. where we were told time and time again we would not achieve the funding would not be there, or we simply wouldn't get it because it was a long shot. And we have gotten multiple offers when it came to our FMEAs, and it was just about the message that we prepared. Jose?
Yes, so one of the objectives, number one, is the challenges obtaining capital funding for facilities, infrastructure, and upgrades. So part of our philosophy, and I've managed over 400 plus facilities, infrastructure projects over my career, is that I always start from the premise that, I have to make a case, and my responsibility is to be able to present the need, but it's not my job specifically to find the funding. So I always start from the premise and the understanding that I have to discharge my responsibility. We have problems, as you all agree, that we have problems with upgrading aging infrastructure. Sometimes historically, perhaps in your facility is different, but the priority for infrastructure upgrades, from the fire alarm systems to the sprinkler systems to boilers and chillers, so on and so forth, is sometimes not prioritized. And we're always competing with clinical infrastructure projects, clinical expansions, and with other equipment that is certainly more critical. Next is that we do have also the challenge that our facility projects are deferred. Sometimes we make the first cut, and then later on, our funding is cut simply because there are other budget constraints or changes that require then our projects to be deferred. And the next challenge also that we have is the fact that, as we know, we are always competing with the latest patient care, clinical build out or clinical project, quality infrastructure that always puts sometimes the needs of the building and the infrastructure at a second place and at disadvantage when it comes down to the capital funding for facilities related building improvements. So part of the action plan and some of the best, I call it, practices that we have learned over the years is that, so we have to understand, and I think we all subscribe to this, that we have to have a good communication and an understanding that we need to help our leaders to understand the building systems and the infrastructure. For the most part, with a few exceptions, most of the people that typical facility engineers report to may not have any background in facilities or understanding of our world. So it is incumbent upon us to make sure that they understand utility systems, the functions and the distribution. Understanding the limitations of the systems is important. Sometimes just because the administrator might understand that we have emergency generators, you also have to understand what are the limitations. Just because you have emergency generator doesn't mean that every chiller in the facility is going to be backed up by emergency power. Doesn't mean that every air handler in the facility is going to be backed up by emergency power. So understanding the limitations of the system as it regards to a system and utilities response from the emergency standpoint is part of, I call it, the education process. Something that happens as a matter of a conversation, something that happens as a matter of a period of time where you always make sure that you involve the discussion as part of your regular updates and communication with your executive team. One of the areas that I do find it very useful is the discussion of utility failures and taking the time to review the executive failures on a one-to-one basis with the administrators to make sure they understand the root cause. And whenever it's feasible and possible, I always want to be able to entertain and take my administrators over to a tour of the mechanical rooms. I had an administrator, I don't know if he was afraid of the mechanical systems, but we finished building a $14 million central energy plant in one of our facilities. And I tried for months just to please come and let me show you the new central energy plant, state of the art. I was very excited about it. but he really did not have any interest. I got him probably about 100 yards, from the entrance of the facility, and he received a call and immediately turned around. He never visited the facility, even though it was a $14 million investment. So some administrators are more engaged than others. So it is part of our education process to make sure that they understand infrastructure, and it's part of our ongoing process. That way, when it comes down to the capital planning and the request for funding, is something that is part of a conversation rather than it's just something that I'm just going to bring for the first time. So it establishes then the ongoing understanding of our way of communicating with them, the needs of the facilities. And I think very important to that is to make sure that the capital funds are always linked to the strategic plan of the organization. So the second aspect to this is the language of the chief executive officers. And I think that for the most part, we're not talking about English. We are talking about what we call the language of culture. Your facility has a culture, my facility has a culture, and within the cultures, it is basically the way that you do things in your facility and in your world. If we are going to be successful, if we're going to be effective in terms of accomplishing our mission, we have to understand and speak the language of our culture, understand the different cultural needs and requirements, and understand the subcultures within the cultures. So there are typically, and I think there are studies associated with this, 3 cultures within most organizations. You have a culture that is basically a culture that is associated with the operators. These are the people that basically run departments, and these are different departments within the entities. We do have the engineering culture, which is basically the technocrats like ourselves, and IT is part of that culture, which basically are the ones that are responsible for driving the technologies of the system. And then you have the executive culture, which are responsible for the maintenance of the investors, capital markets, and the strategic planning of the organization. So the key is that the language of every one of these cultures is different. And I think part of the challenge is that each individual culture has a language, and every one of us basically looks at the world through the prism of our lens, right? So I'll make some assumptions based on my background. I will make assumptions based on the language of engineering, but I don't, if I don't translate it to the language of the executive, so something will be lost in translation. I think it's important that we have this, what we call alignment. So the next slide, it talks about the misalignment. And this is one of the issues that it's important that we understand that there have to be alignment between the 3 cultures if we're going to have what is called a learning organization. That is an organization that is able to speak and to be able to communicate the needs and to be able to function properly versus having what is called silos. We all have silos within our organizations. We have silos that have to be overcome, but I think that we have to be able to bring alignment, and that means that we have to understand each other's language, and we have to be able to communicate in the form and fashion that allows us then to have our message clearly be understood.
So as,
go ahead.
So as Jose mentioned, the third objective is the portion where we really want to translate how are we getting our message across to the individuals who have decision-making authority? Because a lot of times we'll present the information and there's an understanding of the information. However, there is not the holistic understanding to the degree that a person will act on the information that they have. And a lot of times they want to act on the information, but they don't know the true impact of acting. So the first thing that we specialize in is 1, communication of thought. And one main reason when it comes to projects and the funding, when something gets denied, typically they cannot determine how the business aligns with it. So the outcomes, the clear focus, and the strategic plans of the organization, there can be strategic plans for various parts of an organization, especially a hospital. There's a strategic plan for research. There's one for healthcare. There's one for the academic portion and learning. And then there could be a strategic plan just for the development of the university as a whole or the system as a whole. So this comes up quite often. And others ask us, how have we been successful? Well, I never attempt to communicate in my own language to individuals who are not a part of my organizational culture. And here's the reason why. In most cases, when it comes to communication, specifically at a higher level, there is a portion where they are clearly focused on. If you're in healthcare, we're running a hospital. Hospital, the communication point is the patient. Very rarely will they understand a building because it just does not translate. And this is something that I also discussed with Kim. One of the core means of communicating is go back to the patient. We've seen time and time again where we can even get into meetings where, as a facilities personnel, we'll start talking about COPD and sepsis and migraines and everything else, how lights and can attribute to it, things that happen to a patient, and they want that room to be a certain way. But what we've come across is how do you communicate? So specifically being in a healthcare organization, I am not an MD, I'm a PhD. So my patient is actually not a human being, it's a building. So when they start to talk about COPD, not a problem. It's no different than heating, ventilation, and cooling for us. Sepsis, a bacterial infection of the bloodstream, is no different than our building having Legionella within the pipes. Chronic migraines, for us, electrical failures. Degenerative joint, you can correlate that to depreciation or the building's age. Hypertension is something they specialize in. We just tell them about plumbing. In immunocompromised conditions where things are off, we specifically discuss temperature and humidity and pressurization. So whereas they want to hear about a patient, we just frame it in a manner that they can relate. You want to hear about a human patient. Well, my patient is the building. The same way that a human being can become sick, there's sick building related illness. So once you have them with the attention of, okay, there's a measure that allows me to adapt the information that I have and fit it to an individual who is focused on a human, you can paint a better picture. And when you're able to paint a better picture on care, sometimes care might come at a cost. And that's when you kind of transition into your secondary component of what is the cost, but the focus cannot be on costs. I mean, every organization has a multitude of individuals who specialize in finances and costs. As Jose has previously said, we never go in and discuss immediately the cost because it is not our overall job as safety professionals to discuss the cost of how to secure funding, but I will tell you the cost of what we have and the projected what it might take to remediate the situation. So Jose, tangible measures?
Yeah, from a healthcare perspective, I think that we have to understand in our process of justification that we have the tangibles and intangible measures. And most of the healthcare projects typically are justified on the basis of the return of investment based on tangible assets and depreciation schedules, things of that nature, and the return on investment. But sometimes some of the projects that we are responsible for have other, in addition to the specific ROIs, they have some other intangible measures. They are more difficult to basically address and to put a cost to them, but they certainly have a significant impact on the projects. So part of our challenge and part of the way that we translate the language of the engineering to the language of the CEO is to be able to know what are the impact of any project in regards to the intangible assets and how is this project will benefit then the overall organization in regards to the rate, the return of investment based not only on the tangible, but also the intangible assets.
And that gets us to a couple of the key points of communication that I use. A wise man once gave me a book that was Never Split the Difference, which was Jose. And these are three key components that are always effective. And one, understand the rules of engagement and communicate in that manner. If you are specifically discussing an upgrade that needs to be made to a portion of the building, and it is to a plethora of physicians, speak in their terms. What does it do for them? How can they see an impact by us either pursuing, foregoing, or delaying this process? The second thing, never communicate from a point of weakness. There have been too many situations where we go into a meeting and I will sit and witness people shoot themselves in the foot all the time because they immediately think it is too much money, I'm not going to get it, and who is going to properly present this in a way that we can actually compete with another clinical or clinical department within the organization who may be doing something that is going to bring more, let's just say, attention to something specifically. So I always take the thought process that why not me? And anytime somebody starts to say, you know, but what if we don't do this? I immediately turn it around and say, but what if we do? Because all too often we will think of a billion and one ways to not pursue an activity when we in fact just need to modify the mind frame that we think in the positive, we move in the positive, and therefore things will come out positive. And the last thing that we do, anytime you hear, let's say a chief talk to you and they may relate, let's just say, you know, well, that seems like it's going to be a lot of funding. And you pretty much just mirror certain conversations where, okay, it seems that you have an issue with not necessarily the project, but the funding. So you carve out definitive issues within a project and a plan, and you don't apply the generalization to the entire scope of the work. Or it sounds like this is going to be a lot of money. Well, okay, not a problem. From what I understand, you have a problem with 1, 2, 3, and 4, but the major issue is that it sounds like it's going to be a lot of problems. So the fiscal responsibility of pursuing this action is what's weighing on you. And Jose will actually tell you something about this portion, which is very important.
Yeah, this is a mindset. Typically, if we have a project that we are very passionate and we believe about, that this project should move forward. So what we hear is, and no to me is, and to us means KNOW. It's no, meaning that we definitely need to provide additional context, additional information, so they will know what is required for the no to be converted into a yes. And I think that's part of the way that it frames our conversation. Sometimes we have not been successful, and we go as a team and we meet and we say, hey, this particular project did not get the approval or the engagement. What do we have to change in terms of our approach? How can we present this information in a different fashion? And some of what we're going to share with you basically comes out of this understanding. And no is not always a no, it is a KNOW.
And this is the process of shaping the reality of the conversation before it can be created by others. So one of the core components, even when we present information, we very rarely use as much text as you all are seeing now. We use a lot of pictures because it makes an individual come back to the originator to communicate exactly what was being expressed here as compared to taking information that you taken out of context and presenting it themselves. So the last core component of communication is these three things, right? So the first thing you have to understand is whether or not a senior leader has given you a counterfeit, a confirmation, or commitment yes. And there are vast differences between the two. In most cases, we are unable to distinguish the counterfeit yes from an actual confirmation yes because they sound the same. This is when an individual will say, yeah, we'll do it, but it's really just an easier way to get out of the conversation. Other cases, there'll be a confirmation yes, as in, so do you think this project is something that we can all vie for support on? Yes. They confirm that they can vie for support, but there was no commitment behind the confirmation. So what we should always be seeking is a commitment yes. This is the true and final yes. They sometimes can sound the same, but the commitment, yes, is actually a result of us going around and essentially, can you support this plan? Can you support this plan? And you get that commitment up front. Therefore, you X out the possibility of a counterfeit or a general confirmation to get you out. Jose?
Yeah, understanding the return on investment is one of the things that we mentioned before, but to incorporate the return on investment on intangible assets that are associated with the project to is a key, and a key that allows facilities, projects to compete on the equal basis with projects that have a tangible return on investment. So the next slides are just going to be very quickly, just so we all have the same frame of reference: tangible versus intangible assets. The tangibles are the physical assets, and basically are used to produce services, and intangible assets are the non-physical assets that have a monetary value, but and they represent potential revenue, but they are difficult sometimes to quantify. So the first thing that we must do is first seek to understand, and for every project we try to understand what, from the, if we are the sponsors of that particular project, is what are the specific tangible and intangible assets that are impacted by this particular project. And just to give you an example, these are examples of intangible assets, and we'll use some of them as are appropriate within justification of some of the projects, and especially it's part of the translation of, as you'll see when we get into the FMEA. This particular chain of impact is part of the book, Measuring ROI in Healthcare. Is a great reference, and we provide the reference at the end, but it basically guides you to the process just to analyze the impact of intangible assets and how to use them to justify capital projects in healthcare settings.
So business impact analysis. I am a master business continuity professional, which is one of just about 500 internationally, but my field of study primarily is emergency management. So something we're very used to is business impact analysis. Now, when it comes to failure modes and effects analysis, this is the core component that will lead up to that business impact. And it's just communicating in your measure of currency. Some people, like a finance department, should communicate in the method of numbers. Clinical departments can communicate in outcomes, but when it comes to facilities, we typically communicate in a measure of compliance, safety, and rates. So the general FMEA process is just a systematic, proactive approach to identifying risks and their potential impacts. And this is actually something that occurs using a preventative measure. So a lot of the times we're doing root cause analysis because something has already occurred. Well, we wanted to get on the leading end of it and try to find those proactive measures before we have to react to something. Typically, you're going to get those key indicators of small problems that have come up. Once they start to happen 2 and 3 times, then it's a pattern, and those patterns are what we should be following. So general gist of the failure modes, we start with what could possibly go wrong. And then we list all of the possible issues that we can immediately think of the first time around with a specific problem. And in a few slides, you'll see the actual diagram that will bring this more into context. Then we look at the causes. Because something occurred, what would happen? And we attempt to list all of the possible causes that could occur specifically due to a problem. And the last component of it is the effects. we immediately start about what can happen, what will be the causes, and what are the effects that we can potentially experience by either delaying, foregoing, or completely going through with a project. At the bottom portion, the way that this is calculated is going to be using pretty much three different types of numbers. One is occurrence, and we want to know how likely is something to occur on a scale of 1 to 10. When it comes to the likelihood of occurrence, the one thing that we want to remember is that it is somewhat subjective, but if you're looking and you're scanning through your historical documents on failures that have previously occurred, you can, in fact, dig out the likelihood that something will continue to occur if no mitigation is done. Detection. This one, depending on what you're looking at, it is a very unique number because there are some failures that can occur and you will not, in fact, know it until someone has been harmed. There are other failures that you can, in fact, detect through sensors and other things that we can kind of look at. But the ones that have the detection where the rate is extremely high, where there can be potential loss of life or harm, are the ones that we focus on because we know for a fact if it occurred, we are less likely, and that should be found in your causal and your effects analysis as well. And that'll generate a risk priority number. So it's the occurrence, by how likely it is to be detected, and the severity of it when it does occur, if any. The lowest possible score is 1, and the highest possible score is 100, which is 1,000. Now, anything that goes up pretty much past 700, we consider it to be extremely high risk. And we want to get everything back down to right around 100 and 200 because you can never have zero. Risk will always be there. All right, and mitigation, which we discussed. So what we always say to get to the point that you all want to really see is if a picture is worth 1,000 words, then how much is a science-based diagram? What was it?
Yeah, so this is just basically statistics that indicate 65% of people, including myself, were visual learners. So we acquire information from a visual perspective better than just by reading. The human brain processes visual information 60,000 times faster than text. And it is incredible the amount of information that we can process just by looking at and assimilating information. And it happens very quickly. Sometimes without us being consciously aware, we can actually receive information that is being analyzed by our minds. So overall, it's understood, and I think is part of the current research and understanding from a learning perspective, that there is an improvement in learning and retention of 400,000% when visuals are used in the process of communicating any information. So that brings us now to what we call, this is the visual FMEA infographic. The beauty of this model is that it takes a dull process like the FMEA. When you look at an FMEA, typically you're going to see a series of sometimes tables. You might see, in addition to that, some flow charts. But what we have in here is a new way of looking at FMEAs because it summarizes everything in that infographic fashion. Walter?
So there are certain situations where you can have the regulatory agents, but when we looked at the potential failure modes, and this was actually our first go at this document, we were facing a huge systemic issue where senior leaders were losing their jobs all because of temperature, humidity, and pressurization. So for those of you that are facilities operations staff and personnel, this is a critical component where there was a mass war between leadership, infection control, and facilities, all because we did not conclusively understand how to look at the model. So using this one, we start out with the potential failure modes. But we looked at the Joint Commission standards and NFPA to specifically target the operating theater instead of a room because there are other core components that need to be reviewed. And we listed all of those potential failure modes. And then we turned around and we start analyzing, okay, with those specific modes of failure, what would be the effects? One of the core issues that we found out was the interruption of surgical services. And on average within our system, we noticed that there was an approximate 10 to $20,000 loss in revenue per every hour that an OR was down. And when we're looking at temperature, humidity, and pressurization, we were having those services delayed for sometimes up to 4 hours as they worked on a specific room. Then we got into the process of a detection, like what measures can we use to detect that something is in fact wrong before we even get to it. And our actual outcome ended up being a policy. We had a lot of the core components that were in place, but the understanding of when. And I've always been pretty much under the moniker that of all the 1,000 best options, knowing when is always best. And it was that assessment that led to the risk. When we presented this to our chief leaders, the first thing that they went to was the immediate red. That is something that would definitively catch their eye, and they would specifically ask about the 900. Why is it so high? What do we do to get it back down? And that bridged the conversation that we could have between the groups. So
Yes,
after a while, we started to get a little bit better on them.
yes.
Go ahead, Jose.
No, just one point in regards to the temperature, humidity, and pressure. There was a war between different factions and different cultures within the organization, and it was very heated at times. But the understanding of all the different concepts and ultimately resulting into development of processes from the facilities perspective and a risk assessment process that is now used. So now we have, as a matter of fact, just basically a peace, if I can say, peace within the different factions. And now there is a clear understanding of what is everybody's role, and no one panics because the relative humidity is somewhere about 65%. We just have a specific approach to how to deal with that and the time frame that we use to communicate the expectations and needs of every stakeholder, from the physician to the infection control to the facilities administrator.
And even in this one, you can still see that the occurrence, it still happens a lot where there's something that can be out of range or pressure out of range. And it can be for a multitude of reasons in the operating theater. And the severity of it, because it is a clinical space, is always high. We have a better measure of detecting it when it does occur, which brings that number down. So this is another one, and I'll kind of let Jose go with this one where we immediately
Yeah, this was a significant challenge for our division. So as I mentioned before, we had 2.5 million square feet in our healthcare responsibility. This particular building was not part of our responsibility, but they added some clinical spaces in here that became part of the license for the CMS and also for Joint Commission accreditation. And at that point, this building became the center of attention for us. So we had some challenges with this building. It was built in 1965. The building, the density had increased threefold since the original construction. And the type of patients that are now being seen in here, rather than just being office spaces, now we have clinical spaces in here, and we have different type of patients. Some of them are incapable of self-preservation. And what you have is a building that is non-sprinkler, a building that has limitations in terms of the evacuation and the size of the stairwells. The fire alarm is antiquated. The fire pump is only, has to be replaced. We have problems in regards to the size of the elevators for evacuation purposes and even taking gurneys up the building. We do have in this building all kinds of other compliance issues. One of them is, you have patients that are brought in stretchers up to a particular department. They are left in there by CMS, or by the ambulance service. And then 4 hours later, then they are, taken out of the building and removed. So how do you evacuate those particular patients if you don't have, evacuation zones, you don't have sprinklers? That became obviously a significant issue for us. And we needed to be able to bring all that in a fashion that was understood. Oh.
All right, and Jose, we'll get through the last two and then I'll go back to it.
All right. So in this particular one, we had issues associated with our central energy plan. We had 4 chillers and 3 chillers. And at the maybe 10, 11 year of the life of these chillers, and we started experiencing some problems with motors that were burning. We had some specific issues associated with some of the compressors. The reliability of the central energy plant then began to be an issue for the system, and especially because we were planning to connect the central energy plant chill water loop to feed our largest hospital. So we wanted to make sure, at least our facilities team wanted to make sure that, they have the redundancy and have at least a 5th chiller to be able then to take a chiller offline without affecting the overall capacity of the system. So some of these FMEAs, like this one in here, it's something that, and like the boiler in here, they're brought to us as challenges from the facilities group. And it says, okay, we have failed in terms of being able to get the necessary funding for this project. This one has to do with a boiler that is over 40 years old, 48 years old. It basically has exceeded the life expectancy. It has to be replaced. We have 2 of those boilers in one of our facilities, and we needed to make sure to have the proper justification in terms of what happened. So you can see that now we have the clearly defined the potential failure modes, and specifically the failure effects are very specific to what I mentioned before, intangibles. So what are the intangibles in here? Look at the bottom, adverse impact to the university image, unsustainable financial losses that can happen if the boiler explodes or goes offline for a period of time. We've seen that there have been some from time to time explosions with boilers and some accidents that have occurred. This boilers is specifically located in the basement of one of our facilities, and the electrical infrastructure is right there adjacent to it in the other room. So a catastrophic failure here of a boiler can result in significant damage to the infrastructure of the hospital, and most likely will take months to be able to get that hospital back online. So this is what this is part of the picture that we are conveying with these FMEAs. We take it from the potential failure mode, we give them the potential failure effects, and we take it now to the mitigation strategies, which talks about additional funding that might be required, not as a matter of highlight, but it's a matter of the conversation.
So we switched to this model. The first time when we discussed the no versus no, when it came to the building, we were told no, we do not have the funding. So Jose and I just took it as maybe they didn't understand. Maybe the picture wasn't worth enough. And we ended up creating this guy. So there were issues that we would essentially have to the extent where we built this 3D model of the actual building to scale. We showed stairwells that had issues. We showed the area up top where we would have the chiller sitting in. And what we did, we brought all of our chief leaders into a space, and they were able to view this from a 3D standpoint. One of the core components of the 3D standpoint was actually seeing it from the patient's view. So if it included 3D glasses, that would in fact allow us to look at some of the issues that we had where we couldn't particularly recess this area, or this water fountain was sticking out. A couple of other things that we also looked at. the occupancy load. When it came to the specific occupancy, Jose directly spoke about the building being so packed with individuals past its original design. So what we did, we started and we created this, which specifically tells anything in red is a level where there are 4 or more patients not capable of self-preservation. And we actually overlaid the building with very specific issues that we had. So one of the things that clinicians do understand are suites. So we had the building sectioned where we can look at those areas where this is the actual floor plan of the building. We could look at a particular suite. Any suites that were red were in fact areas where we had persons capable of not capable of self-preservation. The blue areas could have been office spaces. So it allowed us to easily find a snapshot of the building to show him exactly how difficult might this be to create the plan. So when it came to the rectification and the mitigation plan, a lot of individuals, well, what does it look like if you were to start adding different upgrades? Well, one of them, we start saying phase 1A, phase 1B, where we talked about closing off a specific area or a proposed stairwell that would be on the opposite side of the building. That would allow individuals to essentially leave the building with a different level of travel. So let me go to west stairs real quick. When we started to make the proposal, one was, hey, can we in fact do a stairwell? Well, yes, and we put a stairwell onto the building. There was also portions where we wanted to discuss bridges because right now this piece did not connect back to the parking garage, which was an easy way to go through the wall into another fire protected area. Jose spoke about upgrading the fire system. This is one component where we were asked time and time again, well, what would it look like? How many floors? Where are we going with the specific area and the fire protection? And we got it down to the granular level where we actually had the true design of the new fire pump that would be included into the system. We put it right into the diagram. Something that everyone was worried about was the interior ingress. So what we did, we spliced the building in half and showed, right now there are really only 2 different ways to get out, and you have to go directly across the building in some cases, although there's this stairwell here. And then we kind of gave all of the upgrades that we proposed and we wanted to do, whether it was increasing the stairwell, adding other areas, safe areas of refuge, additional egress, or just all of the upgrades, looking at the skin of the building and what would be modified. Jose?
Yeah, so the overall impact of the presentation and the summary of the FMEA. So we obtained an $8.5 million funding just to begin the process of implementing these recommendations. The sprinkler, the fire pump, and the fire alarm system upgrades are already in the planning process, and the rest of additional enhancements are being planned and studied to see which ones do make sense. But this is an example where for 5 years, our facilities group was unable to even get $1, not even just to be able to change a simple fire pump that was very antiquated. But we basically thought outside the box. And this is the model that allows us to bring the engagement and speak the language of our administrators, because immediately they actually understood. So one of the advantages of, like I mentioned before, is when you look at information from a visual perspective, you engage in the left brain, the right brain, and the amygdala, which is the one that allows you, make those unconscious decisions. We want to engage the emotion of our administrators in this process when they receive the information that we're communicating to them.
So we say that we're those facilities guys and not an MD, but a PhD, and our patient just so happens to be a building.
Yeah. Wow. Yay. Brilliant.
Yeah.
It's really brilliant way to change the perspective and engage people in a different way and help them to know and really to understand. I loved it.
And my mic was on mute. I gotta give you a clap. I'm sorry. That was good stuff. That's
Yeah.
best in class. Now we need to multiply that across 5,000 hospitals.
Yeah. Well, it's brilliant. It's really a way to not just accept. There were so many things about what you said that were brilliant. You know, not just accepting no, rethinking and going back and not just giving up, but really rethinking how you could present the issues and using the FMEA and the visual presentation of the issues. I think was really, really very cool. Comments or questions for Jose and Lamar, Walter? Yeah, Lynn.
Yeah, I thought that was really compelling. I really, and to be honest, I mean, there are parallels there for all of us, no matter what industry, right? What program did you use to animate the space?
So that one was SketchUp, but we also use Magic Leap. So what we didn't say was there are goggles that the actual leadership team can put on, and it puts them in that building, and they can walk directly through the floor because we've already mapped them out. So we started the project based upon NFPA Code 1600, where firefighters would often ask us, hey, what is in this room? And it's one thing for us to show you how to get to a particular area, but it was like on a side-loaded box where they just loaded into the headset and we could walk them through that building. And we started to train them so that we can have that better functionality. And it just so happens that sometimes when the leadership didn't want to travel, we just give them the headset and let them go directly in.
Yeah.
Yeah. That's so cool. Excellent. Nice work.
Yeah. Other questions? Richie, it's like you want to say something.
I don't have a question, but I thought that was fabulous. You know, I'm going to use a personal example. You guys said, you know, use the language of your audience. At one time I presented the facility issues like knocked off thermostats and other issues, but used clinical terms for the cardiac nurses that I was speaking to. And so I had a picture, you know, you're talking about visual learners, right? Had a picture up. I had the word, the clinical word at the top, and then the definition at the bottom. And so as I flipped the slides, they were already laughing before I even started talking because they already saw their word, and they thought it was great. And I did that like a year and a half ago, and they still talk about that meeting. So I totally agree with your sentiment of using you know, clinical terms to describe facility items, and it definitely is powerful. So
Absolutely.
good job.
Thank you. And that was one of the core components that we ran into, where when they can definitely understand that their patient is sick, but for us, when our patient is sick, everything in it is sick, including yours. So once we got them to understand that core component where, hey, our patient is just a little bit different, but you know, there still might be a little bit of osteoporosis and those types of, they immediately jumped onto it and was like, okay, so I guess a patient can be a building. Yeah.
Yeah, that analogy's really powerful. And then, you know, going through and doing your diagnostics and making your differential diagnosis and then coming with your solution is really very, very cool. So
That's our treatment plan. Yep.
Yeah.
Yeah, absolutely right.
There's one term that we use about ourselves is we are the other side of medicine, because
Yes.
without us, you know, then the clinicians cannot do their function.
Yeah. Yeah. It's great.
Okay, so now you guys have to go to like I don't know, an administrators conference, like an AHA conference, and share that. I mean, this connection is so needed in the industry.
Yeah. They have to.
Ash could help you do that. Yeah.
Well, we should have them write up something for our healthcare design conference too. You know, I think that would be great. You know, submission for that.
Yeah. Yeah, that is really good. Good. I love it. Thank you.
Yeah. Patrick, Mark, any comments or questions?
I thought it was great. I thought it hit the nail on the head. The one thing that sticks in the back of my mind, and maybe Walter or Jose can comment to it, is we still have the naysayers. They go, oh, that's all good and we get it, but we got no money. So they immediately throw you back to square one to try to start all over again, to say the patient's going to die if we don't do something. And they go, but we got no money. They use that as I don't want to say an excuse. Look, they've got the money. It's a matter of prioritizing the money. Okay. And most of the time I lose out to the, OR suites or something that want a, new 360 slice CT or something because it has a return on investment of 1.5 years versus something to like a fire pump or infrastructure that may keep them safe and may in fact be needed, but it doesn't necessarily bring cash to the bottom line. So there's some people out there that, constantly throw that back out there to try to create this, I'll say, roadblock.
Yep.
Yeah, Mark, I've experienced that too, but then I use the fact that it takes $100 coming in the front door to spend it out the back door, like for utilities as an example, right? So if we can save it on the back end, then we actually improve the bottom line on the front end.
Yep.
And a core component of it that we jump back to, because they undoubtedly have said the same thing to us, where we do not have the money, then what exactly is the cost of a life? Because this is what we're getting back to in the heart of it. The portions where we describe our terms to them, whereas, hey, you can take XYZ amount of money and we can get this return on it. This is where we change our currency. Our currency might not be the physical dollar, but it just may very well be the community and essentially the clout that comes along with Press Ganey scores. Physicians love their scores. You can have XYZ amount of patients, but if they will not come back, that is going to be an issue. So we always push the decision back directly to them. Okay, so you're telling me, or it seems like you're telling me that you don't have the money. But what I do hear is that we need a more effective way of determining how to appropriate the money that we do have.
Right.
I am not a person that takes no for an answer. If you tell me no, it is obviously to say yes to something better. And I just need to figure out what something better is.
Right. So it's just the emphasizing the intangible for us. And we all experience the same thing that Mark was alluding to. Everything that we presented to you, with the exception of the temperature, humidity, and pressure, the facilities group came to us simply because there was no money. They told us there's no way. And they gave us $8.5 million, even though there was no money. We always know that there's money. It's just a matter of the priorities. So our job is to make sure that we make a compelling argument and that we can present it in such a fashion that it moves them. So it moves me first. Does it move us, and then does it move them? So there has to be an emotional attachment or meaning to the presentation. And that's part of, to me, putting in this context has allowed us to have that type of conversation. The boiler, we had $1.6 million, and they say, we ran out of money. The other one for the chillers, they gave us $3 million. So those are facilities projects. So you have 8.5, 3 million, and then you have another 1.5 million in here, all at the time where all the funding was exhausted. We always know that there's more money. It's just a matter of making sure that we hit the button that resonates with that administrator. So it's
the very last thing we do want to get out to show just this small group, since we have you all, because I know that there's been the information from pandemics. So just a brief snapshot of exactly what we are doing and theoretically how we should be managing it, because I know, Mark, you asked the same question. And I'm going to show this very quickly. Give me 1 second to share my screen again. Okay, can everyone see my screen?
Yes.
Yeah.
Okay, so Here is something that we're theoretically going to do. It is the hierarchy of controls when it specifically comes to safety. How did we get into this situation? I wanted to purchase about $65,000 worth of PAPRs ahead of time when we first ran into this issue back in maybe last September, August, where we had a bunch of individuals present to the hospital. They had flu-like symptoms, but no flu every time we tested them. So to me, as a disaster scientist, that is a clear-cut model that we're probably going to run ourselves into a pandemic because the perception that we have is not meeting the reality that we're facing. The problem, what we're hearing from our current administration when it comes to the CDC and OSHA is what you see on the left-hand side with the hierarchy of controls: eliminated, substituted, engineered out, administrative, and PPE. Here's a huge problem. The hazard is no longer a specific hazard in the environment. As Lynn said, the virus does not travel, okay? People do. So therefore, the hazard is actually a person, and therefore, you would have to invert the current hierarchy of controls in order to effectively manage a pandemic. So we did a brief test, and that test was from data from other countries. Countries that follow the left-hand side of the focus, where there are normal operations, normal hierarchy of control, are actually doing worse than those countries who changed around and those organizations who have actually managed it in an inverted manner. Why so? We cannot effectively manage occupational safety and occupational health in a manner that is conducive for public safety and public health. So on the left-hand side, we see occupational safety and occupational health, which a lot of times we're being told to do when we should be managing from the right side, public safety and public health, which is one, put a mask on. It's okay. Masks, we love them. Wear a mask. Two, change the way people work. Okay, the whole social distancing, no, it is a physical distance of about 6 feet. Engineering controls. This is the core component where everyone focuses on, oh, well, what is my HEPA unit, the HVAC system? Engineering in neither one of the models, the model that is historic to OSHA and NIOSH, Occupational Safety and Health, and the model that we're creating here, which is inverted. It is never the first, never the last. It is always a core component. You try to isolate people. On the right-hand side, the substitution of the hazard, yes, we can have individuals work from home, but we will never be able to eliminate it when it comes to the virus because we, one, would need a vaccine, and a vaccine, in fact, needs to, one, work its way through the system and get to the point of immunity, which there are very few that we have eradicated conclusively. So when you are speaking to your groups, this is just another one of those practices and protocols that we're going to mention when it gets to Grainger Summit. Let's use the model that tentatively Dr. Shukla, Jose, and I are actually working on, but we found that the efficacy exists. And if we just manage it from a public health, public safety standpoint, we will get rid of the issues that we're occurring with occupational safety and occupational health.
Yeah, I love it. I love the reframe. It's great. I see a question from Lynn saying, what if Press Ganey began scoring the safety of the building or people's perception of the building? I don't know if that Press Ganey asks that so much, right? Do they ask for?
No, it's a very indirect. There are only two questions that sort of relate to the physical environment, but they don't really get to the heart of the issues. Wouldn't you agree?
Yeah.
They really.
Temperature and noise, I believe, are that question specific to Press Ganey.
Yeah, and they ask a little bit about the overall aesthetic, but if they were really allowing a score that the public could understand as it relates to, like, would you go to that hospital that you just showed me a picture of? You know, I mean, we all know enough to be dangerous, right? Because we're in the industry. But what if the public knew that? Then you would get a lot of pressure put on that CEO,
Yeah,
you know, or the administrator.
Yeah.
And that's what we conduct our rounds, and we essentially create our own Ramirez Lamar score for the physical environment, because what we want to get them used to is, hey, I understand that you care about your patient, but your patient is inside of our patient, and therefore we need the holistic environment, because from the moment the person reaches the door to the point of contact with someone else is really all of the surfaces, the devices, the equipment. It is all intertwined. So when they try to extract themselves from the facilities guys, we bring them right back to the other side of medicine. You are a part of us, buddy, and it is not going anywhere.
Brilliant.
So that's pretty much it for us.
Yeah, that's great. That's great. Patrick, I think it's Patrick, right? Do you have any questions or comments?
It's Parker. Sorry, I'll have to change the P. No, it's okay. Parker's not that common. Patrick and Preston are a little bit more common. No, I think it was great, guys. We're a little bit different, and so, but I think a lot of the same structure applies, and I think that this is just something that a lot of senior leadership really hasn't really been forefront for probably the last 30 years in facility management, because buildings relatively have been younger and people haven't had to make these really hard decisions. And so one of the things that, we're working through the exact same process here, very different scale, right? Ours is not large sites. Ours is large portfolio of small sites. But what we work through on our side is creating a matrix, essentially. You create a formula, you agree on it at the highest level to include our ownership structure, right? Because I think that's one thing that we sometimes, we're purists and we live in, it's broken, we need to fix it. And so we go back to, hey, this is our ownership structure. We understand this is our reinvestment cycle for our REIT. Here's where we are currently. Here's where we may be in our next transition. And then create that, right? And everybody agrees on a formula. And then you allow the formula to work and say, this is what comes out of that formula. Here's how we're going to invest in clinician improvements, and quite frankly, from a renovation standpoint, hey, we're improving the visual appearance of a physical structure, but not quite, maybe not the underlying health or the compliance safety. And then we all agreed, right? We said, hey, we all agreed to be able to maintain these structures the way that we want to. Here's the system, here's the formula. Let this formula work. Every single time we go back and say, no, we want everyone to run to the left side of the ship. We just remind everybody, every single time we go to 100% marketing focus, we will have things that are deteriorating faster and faster every year. And I can say for our leadership team, they never had that, right? They never looked at it at that kind of level. And I think for what you guys are doing is essentially the same thing, just a different environment, but essentially the building blocks are there. So great stuff. I appreciate you guys sharing it.
Thank you.
Parker, actually, I have a follow-up for Parker. Could you kindly share your portfolio? Can you share a little bit about Trilogy? At one time, I was familiar with those details, but with my responsibilities, I can't keep up with every organization.
Yeah, totally understand. So we're a portfolio of 120 senior care facilities here in the Midwest. We're in Kentucky, Indiana, Ohio, and Michigan. We're about I want to say right now we're up about 16 million square feet of senior care. What else do you guys want to know? I know that's kind of a little bit different than this environment.
Assisted living, independent, continuity care.
Yeah. So
what's your service line?
Yeah, sure. So we have 3 service lines. We're skilled nursing, we're independent living, and assisted living. We typically have all of those on the same campus. We do have a couple portfolios that are a little bit different that are kind of out of that, but that's just a product of us being very regionally focused, and we come across some things but those are typically one-offs. We do have one hospital that we manage, but that's the exception, not the rule.
Got it. And you're national facilities leader, and what's your role again? I apologize.
So I'm the vice president of facilities, so I oversee the entire kind of, to Walter's analogy, I see the envelope. That patient is mine, so I oversee all of that for all of our facilities here. We're only in the Midwest, so we're Kentucky, Ohio, Indiana, and Michigan. So we're pretty centrally located.
Great, thank you.
Parker, are you given some of the issues with COVID and the changes that you've had to make just with the care delivery in terms of isolating people and not having them congregate in the dining rooms and things like that? Are you rethinking the whole design and what you're going to have to do going forward? Or are you just anticipating continuing what you're doing and then hopefully go back to the original delivery?
Yeah, so good question. You know, our facilities are not set up to do a lot of the same things that a hospital is, right? So, I mean, early in the process, it was, what do we do when you don't have a facility that's designed to create a negative pressure period? And so then the art comes in, right? And that's probably, I talked to our leadership a lot about, we're 90% art at this point. Like, I mean, we're using a lot of really kind of off the wall stuff to try to make stuff work. I mean, we're picking up field manuals from the Army of how to do forward preparedness in emergency pandemic environments. I mean, we're kind of doing it all. To your question, we are making some long-term changes around it, not specifically back saying, hey, we think COVID's going to be here forever, but we're essentially saying, hey, now that we really feel it's very painfully, what are some other things that we should be planning for, and how do we make sure that those are getting into our plans early in the process that we can make sure? So, looking around, how do we make sure that CDIF and MRSA, which we experience, how can we start to address those a little bit more effectively than maybe we have in the past, and giving ourselves some flexibility. We're fortunate as a company. We are single rooms. Most senior care facilities are semi-private, but we have moved traditionally in the private direction. We're going to continue to move that way going forward, almost exclusively.
Yeah, you've got some challenges, but using this approach might help you, I think, potentially get funding for some of the changes that you need to make, right?
Yeah, and we've been very fortunate. We've been able to make some pretty big funding changes to apply to things that we need to very quickly, which have been good.
Yeah, great. Well, Jose and Walter, thank you so
Very
much.
much.
I'm sorry that we didn't have more people to actually hear it, but Jill recorded it and we'll get it out to the entire group and encourage them to listen, because I